Hello, everyone, and welcome to another webinar in our Health Reform Beyond the Basics webinar series. Thank you so much for taking the time to join us today. Most of you have been a part of our Beyond the Basics project for quite some time, but for those of you who are new, I'm Hallie Cloud, and this is a project of the Center on Budget and Policy Priorities. It's designed to provide training and resources that help explain health coverage options available through the marketplace and Medicaid. It is aimed at healthcare assisters, advocates, state and local officials, and others who help people get and keep their health coverage. We at the Center are a policy nonprofit in DC, and as a reminder, this series is intended for those working on the implementation of health reform and is not intended for press purposes. In today's special presentation by the American Association on Health and Disability, we will address disability etiquette and basic accessibility considerations for anyone doing enrollment work, as well as provide an overview of questions a person with a disability needs to think about when considering their healthcare options in the marketplace. So with that, I'm going to turn it over to our presenter today. Please welcome Carl Cooper, who is the Director of Public Health Programs at the American Association on Health and Disability. So welcome, Carl. Thank you so much.
Thank you, Hallie. I appreciate being on the webinar series again, and it's always a privilege to be able to talk to people who are doing healthcare enrollment work for the Affordable Care Act and let them know what they need to be thinking about for people with disabilities as they're considering their options that are available to them under the Affordable Care Act and the marketplace plans. First of all, just a little bit of background for those of you who may be unfamiliar with our organization, the American Association on Health and Disability, or AAHD. We have a stated purpose of promoting health and wellness initiatives for people with disabilities. So we are cross disability, and we are also across the lifespan. So we work with from children all the way up to older adults, and looking at what they can do to help promote their health regardless of their disability status. We do that through four main objectives. We work to reduce health disparities for people with disabilities. We advocate for community inclusion and making sure that communities are accessible and available to people with disabilities so that they can access services. We also promote full accessibility in the healthcare field. And we also work to integrate disability into the public health agenda. So the way we like to describe it is we like to look for the cracks of public health initiatives that are going on in the country and making sure that people with disabilities are not falling through those cracks. But we want to make sure that they are fully included and are able to participate in all of those health and wellness initiatives. A little bit just so you know about the disability community, because if you're going to assist a population, you want to know a little bit more about them and just have a better understanding of where they're coming at from a health perspective. One of the common questions I get lots of times is, well, how do you define disability? How many people have disabilities? And those are questions that depend, the answers to those depend on exactly how you do define disability, because there are a few different definitions of disability when it comes to federal law. The most common federal law that's known is the Americans with Disabilities Act, and that has a very broad definition. And we generally, if you hear the 1 in 5 number, that 1 in 5 people have a disability, that's generally the number that they're talking about, is the very broad definition of disability and those people that are protected under the ADA. If you look at the definition of disability, for instance, under the Social Security Act, where you're talking about disability benefits under Social Security, it's obviously much more narrow, and that's obviously a much smaller number. But for the purposes of the statistics I'm going to be providing you with today, we're talking about a number that's somewhere in the middle. And according to HHS, 12.5% of the population has a disability which seriously limits them. So that's 1 in 8 individuals would fall under this definition of disability. Within this group, people with a disability are over twice as likely not to see a doctor due to cost. And that's obviously very important as you're looking at plans for people with disabilities on the marketplace and making sure that things are affordable for them. They're also over 30% more likely to be obese due to inactivity generally. They're 60% more likely to smoke, which also leads to a lot of issues with and around mental health and depression. And also they're over 2.5 times more likely to develop diabetes due to their disability. Women with disabilities are less likely to both have a current mammogram and current pap test. People with a disability are over 3.5 times more likely to have cardiovascular disease in the age group of 18 to 44, so younger adults. Once you get into the older adults that are up to retirement age, the number gets a little better. It's just under 3 times they're more likely to have cardiovascular disease, but that's obviously not because people with disabilities are getting healthier. It has to do with the fact that the people that are their counterparts in their age group are getting less healthy. In terms of social determinants of health, people with disabilities have double the unemployment rate among those within the workforce, and that within the workforce is key. We're not talking about people with disabilities who are unable to work. We're talking about people who are able to work, who are looking for work, who are active in the workforce. They still have double the unemployment rate among those individuals. Now, one of the things we like to specifically reference then with this is, as the economy gets worse and improves, those numbers pretty much stay consistent. So when you had the Great Recession at the end of the last decade, the unemployment numbers for people with disabilities were still double the unemployment rate of the nation. And as things have improved, things have also improved for people with disabilities, but still remain about double the unemployment rate. They're also about 35% more likely to have less than a high school education. And they're also less likely to report sufficient social and emotional support, which obviously has a great effect on health. I put this graphic up there to sort of underline a point, and this goes to show in terms of how disability and age relate. You'll see that these were numbers from the 2010 National Health Interview Survey, and it shows people with disabilities as a percentage of the various age groups. And obviously, for younger people, the percentage is much lower. And then as people age, the percentage goes higher. And generally, we look at people who age into a disability, and then those who either are born with a disability or have their disability acquired much earlier in life. And many times those people have very different views on their disability. People who have a disability who they age into it usually are much more fatalistic, for lack of a better way to say it, about their disability, and just to sort of have the attitude of, oh, well, this just happens when you get old. Whereas people who have their disability earlier in life generally have a much different outlook about their disability. They've learned to adapt, and they expect to be able to fully participate and be included in various programs and services that are available to the public at large. So as a result, lots of times those different disability groups might have very different views about what is available to them and what should be available to them. And as you're thinking about accommodations, that's usually an important distinction to make. It's not necessarily that the people with who age into a disability aren't entitled to it. It's just they might not realize that they're entitled to certain accommodations because of their disability, because they may just have just sort of an oh well attitude about it. So let's talk a little bit about disability etiquette. And there's a lot of things that we can talk about when we discuss this. We have a fact sheet that we did on the project that I'll be talking about later that goes into detail on this, but I do want to highlight some of the things that we cover in that fact sheet, just so you can have an idea of generally some pointers really to be thinking about when you're dealing with people with disabilities. So first, generally, for people with all types of disabilities, introduce yourself, offer a handshake. People that do have limited use still usually will shake hands. And this is basically, this first point just sort of underscores an ongoing point that I like to make when you're talking with people with disabilities, and that is just treat them with respect and treat them as you would anyone else. If you feel like you want to offer assistance to someone, make sure you ask before providing the assistance. I myself have a disability of my own, and lots of times I will have people ask me if I need help. And there are some times when, yes, I do need the help. And there's other times that I don't, and nothing irritates me more than either the one thing that irritates me is people just giving me assistance without asking. But what irritates even more is when they ask if I'd like assistance, I say no, and they feel compelled to provide it anyway. So just there's nothing wrong with asking, but then respect the person's wishes if they say that they're fine. When you're talking to them, make sure you're speaking directly to them and not their attendant or family member, whoever is with them. This even goes for sign language interpreters. People have a tendency to talk to the interpreter rather than talk to the individual. The individual would rather have the eye contact directly with you, and they then can sometimes pick up on some nonverbals that you'll be giving off, and many times they'll also be reading lips while also using the sign language interpreting. So you want to make sure you're looking at the individual when you're talking to them. Obviously, something that's very well known, hopefully, is that you're not supposed to pet service animals without asking the owner first. And generally, if they are working at the time, you should not be petting service animals. Asking questions if you're unsure how to proceed is always a good idea. Most people with disabilities are used to having people ask questions about what assistance they need, and that's actually refreshing to hear, and not having people assume things about your disability and what you are or are not able to do. When we're talking about people with mobility disabilities, you don't want to touch or push a person's wheelchair without their permission. That's essentially the same as if you would just push someone who was standing who didn't use a wheelchair. You wouldn't do that, so you shouldn't do that with a wheelchair either. If you're having any sort of prolonged conversation with an individual, the one thing I do use a wheelchair, and the one thing that I always appreciate is if I'm having a prolonged conversation, someone sort of kneels down and lets me to be at their eye level, so I'm not cranking my neck, looking up at them the entire time, because that can obviously start to bother you if that is the case. So if you are going to be talking to someone that's in a wheelchair for a length of time, it's usually better to put yourself at their eye level. It's just generally going to be a much more pleasant conversation for that individual then. In terms of people who are blind or have low vision, always introduce yourself and anyone else who's present. Obviously, they don't know if someone else has come in the room, so make sure that they're aware of that. If someone has left the room, make sure you advise them of that. Make sure you're explaining any interruptions. If a phone rings or something like that, someone's cell phone rings and someone stops to have a conversation, they aren't necessarily going to always know what's going on around them. So they may hear things, but they're not necessarily going to see exactly what's going on. Offer to read information to a person when it's appropriate. If you are in a meeting with them and you're going over maybe some forms or something, reading the information to the person and offering to read it to them is generally appropriate. Sometimes if it's something that they can review after the fact, if you can send them some sort of digital version that they can use a screen reader with or something, that's also a great way to go. But if it's something you need to go over with them, then offering to read it to them is appropriate, but then once again, honoring their wishes. If you are asked to offer guidance, offer your arm so the person can grab your elbow and then sort of follow you. It's not that's the better way to lead someone, rather than having someone take you taking their arm, and sort of it almost then to that person feels like you're grabbing them and pulling them along. And so instead, offer your arm, allow them to hold onto your arm, and then follow you as you walk. For people who are deaf or hard of hearing, you want to make sure you're getting the person's attention before you begin to communicate, so that they can read lips or whatever it is that you're going to try and use to communicate. You want to let the person establish their preferred method of communication for the conversation. So some of them may want to read lips, some of them may want to use a sign language interpreter, some of them may want to write notes back and forth. Just make sure that you understand what their preferred method of communication is, and then try to honor that. And use gestures and visual cues. So if you're discussing something with them, hold it up and refer to it so that they understand what you're doing. And once again, as we had with people who are blind or low vision, you want to make sure you're explaining any interruptions. If someone comes in behind them and starts talking to you, they're obviously not going to know that. So just make sure that they're aware of what's going on around them. In terms of speech, people with speech and language disorders, be patient, respectful, and sensitive. You don't want to interrupt or finish a person's sentence because that can be very frustrating for them and demeaning as well. And many times you may not know how the person's going to finish the sentence, and you may make assumptions that aren't accurate. And if the person is using assistive technology, make sure the device is within the person's reach so that they can get to that quickly and easily and make use of it if they need to. For people with cognitive or intellectual disabilities, you want to make sure you're keeping your communication simple, using short sentences and completing a topic before moving on to another. If you do have some sort of aid or something that allows the communication to be more fruitful, you may want to do that. And ask the person if they have questions or if they would like you to clarify anything. In fact, generally what we encourage people to do, if you're trying to explain something to them, ask them to explain it back to you after you've done it, because many times people with intellectual disabilities may feel the need to just answer in the affirmative if they feel like that's what you want them to do. So if you just say, do you understand what I've said? They may feel compelled to say yes, as opposed to, what's your understanding of what I just explained to you, and make them voice it back to you in their own words, and make sure that they did grasp the point that you were trying to make. For people with mental health or behavioral health disabilities, if a person seems anxious or agitated, speak calmly, offer to repeat information. If they need to take a break, then you absolutely want to do that. If a person is confused, you may want to try and take something step by step to help them understand it better. And respect a person's choice of language or terminology. So if they do say something is a mental health condition instead of mental illness, you want to make sure you're listening to the request and use the terminology that they are comfortable with. As I said, all of these are found on the fact sheet that we created that is entitled Disability Etiquette. You see the link at the bottom of this particular slide. So all the things I went over are included in that particular fact sheet if you want to break down that information and all those pointers. Some things you want to think about in terms of accessibility and accommodation. So parking lot accessibility, as they're coming in to meet with you, making sure that your lot is accessible. That means a few different things. Obviously, it means making sure that you've got, when we're talking about physical accessibility, that you've got, spaces that are marked for people who need, have a disability parking. And they want to make sure that that's going to be a clear access from those parking spots to the entrance to the building. You want to make sure that those spots are clear of any items that could potentially cause problems. Generally, if for some reason you were to have, for instance, an office in a strip mall with a shopping center, and you're looking at and there's spots there, lots of times people, for whatever reason, will just put a shopping cart in the area that's between the handicap spots. And that can be a big problem for people with disabilities because it could prevent them access to their vehicle if they have a ramp or something that comes out the side of the vehicle, and it could become a real problem. So making sure you're looking for those types of things and making sure those lots are accessible, making sure that the area where they go from the spot where they park to your building is free of obstacles, and making sure that curb cuts are clear and people can get through them is obviously very important. In terms of building accessibility, making sure that the building is, there's an accessible route to it that's clearly marked, and making sure that you can get to spots that they need to if they are using a wheelchair. And elevator accessibility, when someone comes into your building, if they're going to need to use an elevator to get somewhere, making sure things are clearly marked so they know exactly where to go when they get to the elevator so that they can find where they need to go. Ramp accessibility, if you have a ramp that comes up the side of your building or something like that, making sure that is clear of obstacles so that that's not going to become a problem. Meeting room accessibility, lots of buildings are built to code that require ADA accessibility. All buildings nowadays are, even older ones, many have been retrofitted to become accessible. But that doesn't always mean that things are built accessible, remain accessible. And a perfect example of this is many times with meeting rooms. Once you start putting furniture in a room, you're going to start to affect the accessibility of a room, because if there's not a clear way for people to get around that are using a wheelchair, that can become a problem, and they might not be able to get to where you need them to go if you've got things in the way. Restroom accessibility, making sure your restrooms are accessible and clearly marked so the people with disabilities know where they need to go for an accessible restroom. Making sure things are available in alternative formats, and this is goes back to the point I was talking about earlier in terms of meeting with people who are blind or low vision. You want to see if you have something, making sure it's available. If you can have it available in large print if someone needs something in a large print because they can't read regular size print. or having it available in Braille. Many younger people don't even use Braille nowadays, though. They prefer digital content, which can then interact with a computer that they have set up with accessible technology that allows them to read those documents. Making sure packaging and messaging of materials, if you're going to try and reach people with disabilities, making sure that your materials reflect that and reflect people with disabilities in your messaging, so that people understand and understand that they are welcome at your location, and that disability is something that you will be able to accommodate. And font size, as I was talking about with formats, generally you want to make sure that things are available in large print, but also just font size in general, that things are able to be read in a clear way, so that they're done in a way that is with contrast, and it's also large enough so that someone can read that. I do want to talk a little bit about what the Affordable Care Act means for people with disabilities generally, and the importance of what the Affordable Care Act marketplaces means to people with disabilities, because it does mean a lot of things that did not exist before. So, for instance, as a result of the Affordable Care Act, there's no longer denial of coverage for pre-existing conditions. Insurance companies can't cancel coverage due to a serious medical condition, and they can't set premiums based on disability or chronic conditions. And all of these are generally referred to as what we call the guaranteed issue clauses. Essentially, people with disabilities have to be offered insurance on the marketplace and in a health insurance plan to be so that they can access those and get insurance just as though anyone else would, and that the premiums have got to be the same as they are for anyone else. They can, insurance companies can rate you based on your age, but they can't rate you based on your disability. So that's an important distinction, because if this last protection did not exist, the first two would sort of be meaningless, because insurance companies could price people with disabilities out of the market. So it's necessary that premiums are also free of any consideration of disability, so that people with disabilities can get access just like anyone else can. So these are generally referred to as the guaranteed issue clauses, but the Affordable Care Act did more than that. It also, of course, some of the more important things that some people know about is that prevented insurance companies from putting monetary caps, and that is an important distinction. Monetary caps, they still are allowed to put limits on services and therapies and devices and the like. Every health plan is also required to cover 10 essential health benefits, which obviously greatly affects people with disabilities, because it does provide access to medical devices, prescription drugs, mental health and substance use disorder services. So all of those things are required to be covered under the Affordable Care Act plans. And the Affordable Care Act also did a lot with Medicaid reforms, including expanding Money Follows the Person, and also created some other programs that are around Medicaid. And one of the important things you need to know about this generally is just that Money Follows the Person allows people with disabilities to stay in place in their home and receive home and community-based services, rather than going into an institutional setting where many times they were required to receive care. So this brings us all to the National Disability Navigator Resource Collaborative, which is the project that we started in 2013. The NDNRC came out of a concern of disability organizations that navigators and other health enrollment assisters would not have a sufficient knowledge base to assist individuals with disabilities as they made healthcare enrollment decisions. Several of these organizations began discussing ways to reach out to navigators to provide technical assistance and better prepare them for assisting this population of consumers. It's estimated when the Affordable Care Act was passed in 2010 that 3.5 million people between the ages of 16 and 65 were uninsured and also had pre-existing medical conditions and/or disabilities. These individuals ended up facing multiple options when they enrolled for health care coverage under the Affordable Care Act, including Medicaid in their state, possible Medicaid buy-in in their state, possible Medicaid expansion, and of course the exchange and marketplace insurance coverage. And of course, all of these individuals did not have really any sort of background with working with insurance before, because many of them were not eligible to receive it due to restrictions that insurance companies had in place. So it's the mission of the NDNRC to provide cross-disability information and support to navigators and other enrollment specialists, thereby ensuring people with disabilities receive accurate information when selecting and enrolling in insurance through the Affordable Care Act marketplaces. So who makes up the NDNRC? Well, we have 10 partner organizations that are part of this. I won't go ahead and read all of the names that we have. The only thing I'll point out with this particular slide is that we do have a strong collaborative of cross-disability organizations. Some organizations are cross-disability themselves. Some look at specific conditions, whether it's physical, mental health, intellectual disabilities, but they all have different areas that they sort of focus on, and we wanted to make sure that we had sort of a wide variety of disability organizations so that we were able to really show this as a cross-disability initiative. The mission of the NDNRC is to provide cross-disability information and support to navigators and other enrollment specialists to ensure that people with disabilities receive accurate information when selecting and enrolling in insurance through the Affordable Care Act marketplaces. And we do that through a large selection of things that we've done and resources that we've provided and materials that we've prepared to help us do that. All of them are found on the NDNRC homepage, which can be found at www.nationaldisabilitynavigator.org. And you'll see here on the slide that you can that you see is the copy of the homepage, or the top of the homepage that you'll see as you go there. Several drop-down menus there to access a lot of the information. Under the NDNRC materials is where you can find a lot of the resources that I'm going to be talking about. Under the conversations is where you can find our blog. It's where you can find our news to use, and also you can find our archive newsletters there. And then the large picture you see there is a slider that changes and goes through a lot of the different things that we're highlighting at any one time. If you go a little further down on the homepage, you'll find our state resource guide map, which does provide access to all the state pages that we have, which have individualized pages for each state with resources for each state. You'll also see to the left there, we do have a Twitter and YouTube Twitter page and a YouTube channel that you can follow and you can access there. If you want to follow us on Twitter, our handle is just NDNRC. But talking about the state pages, if you click on the state of your choice, it will take you to the state page. On the state page, you'll find information about that state, such as what kind of marketplace they have, whether they've expanded Medicaid. If it is a state-based marketplace, the contact information. We have community outreach collaboratives in some of the states, so if they have that, you'll find the information for that. We also have the information for all the assistive technology programs in each state on each state page. And we also have state-specific resources for all 50 states, and we have state-specific news and the blogs that if they are specific to the individual states. One of the drop-down menus we do have is for resources and links, and there's a lot of different categories we have under there. Enrollment resources that are disability specific. Many of these are from our partner organizations, such as a toolkit from the ARC. Also draft questions on rehabilitation and habilitation benefits from the American Occupational Therapy Association. The mental health and behavioral health section includes resources from SAMHSA, the National Council for Behavioral Health, and Mental Health America. Enrollment resources with populations with special health care needs. In this section, you can find resources from the American Heart Association and the National Health Council. The next two sections, the ACA Marketplace and Medicare and Medicaid, have resources from CMS as well as organizations that are specific to each program, such as the National Council on Aging for Medicare and the National Academy for State Health Policy for Medicaid. Our overview one is our largest category, and the one thing I always like to put out, make a reference on this, is at the very top of that list, I always make sure that we maintain a guide that was put out by the Georgetown University Center on Health Insurance Reforms. They have a Navigator guide that deals with a large area, large portion of the issues that could come up with any Navigator. So not disability questions, but anything that comes up when you're might be assisting in terms of the mechanics of how the healthcare.gov works, to how you calculate certain things, how income is calculated, how households are calculated. All those kinds of things are a great resource that you can find in that guide that they put out. Enrollment statistics contains information that was put out regarding to showing how many people have enrolled with the marketplace, as well as some Medicaid enrollment numbers. And then we also have enrollment resources from the government, includes basic resources from healthcare.gov, HHS, and CMS. And then other enrollment resources includes links to organizations that have been assisting with and encouraging enrollment. Disability Guide is one of the resources that we are the most proud of. It was released in December 2013. It's been updated in 2015. It provides information to navigators and other enrollment specialists about special considerations for people with disabilities as they shop for healthcare coverage. I want to go through some of the basic information about what's included in the Disability Guide. The introduction talks about how the guide is meant to supplement the training for navigators that was put out by CMS and sort of act as a Disability 101 for helping people with enrollment. The purposes of the Supplemental Disability Guide provides objectives of the guide is strengthening disability literacy, helping identify and provide appropriate accommodations, and assisting in identifying issues central to healthcare for people with disabilities. Key questions for navigators is a basic overview of some of the important questions which will be answered by the guide. Who are people with disabilities and what problems and barriers people with disabilities historically encountered provide a basic background for those completely unfamiliar with who makes up the population of people with disabilities and the historic disparities they have faced with healthcare. How do disability rights laws affect the operation of the marketplace? Provides a basic explanation of how the Americans with Disabilities Act affects those who are providing enrollment services. What do navigators need to know about disability? I'll go into that in a little more detail in a moment. And how is Medicaid eligibility being determined for people with disabilities? This begins the basic discussion of the Medicaid categories for eligibility for people with disabilities, and the fact sheets go into more detail on that. We also have 5 scenarios that sort of take you through some various people that you may encounter when you're assisting people with disabilities. And then what type of accommodations should navigators know? In reviewing methods to communicate effectively, this section will help navigators and enrollment specialists understand how they can be prepared to recognize and assist people with visual or hearing impairments. And then finally, we have the list of the fact sheets we have, resources, and our glossary of terms that we use. As mentioned earlier, the section What Do Navigators Need to Know About Disability, go into a little more detail on that. How disability is defined goes over some of the basics of the ADA definition of disability and how that can assist enrollment specialists in recognizing disability among consumers. What disabilities appear on the streamlined application for healthcare insurance or Medicaid submitted through the marketplace. This section addresses the section of the marketplace questionnaire which does ask about disability. I'll go into that in a little more detail when I go through another portion of our presentation. Why is understanding disability important? Navigators and enrollment specialists really need to understand how disability not only affects choices that people with disabilities face in enrolling, but also how the navigator needs to make sure they're doing everything they can to provide services for people with disabilities. What is disability literacy? Boils down to making sure that the organizations have awareness of disability and ensuring that there are appropriate accommodations available. Disability etiquette, this word can be summed up in one word: respect. Don't make assumptions about people and be careful what language you use. As a person with my own physical disabilities, I'm more than willing to discuss in greater detail if you do have questions. My contact information is at the end of the presentation, so feel free to reach out to me, email me if you have specific questions about disability etiquette, and obviously willing to answer any questions at the conclusion of the webinar. What is physical accessibility? Addresses basic physical accessibility and is making sure it's critical that all consumers can utilize the services of those who are assisting with enrollment. And this section goes over some of those basic requirements. How can navigators ensure effective communication? Physical accessibility is not the only issue. The navigators really need to make sure that they can communicate with those individuals who do have visual and or hearing impairments. This section provides some of the basics in what a navigator should consider. And then how can navigators assist people with disabilities evaluate the adequacy of provider networks and how they can evaluate the adequacy of the essential health benefits. The fact sheets address this in more detail, but these two sections begin to provide a basic explanation of what navigators and other enrollment specialists need to consider when assisting individuals with disabilities evaluate healthcare plans. We do have several topical fact sheets we've put out. I'm not going to go ahead and read through all of these. These all can be found at the link that's included at the bottom of this slide. But the first three of these fact sheets really deal with getting to the information that you're going to need to be able to really provide assistance to people with disabilities and getting to exactly the information that's going to allow you to give them the best information about deciding what the right plan is for them. Then we also have a lot of different fact sheets on specific issues such as rehabilitation, prescription meds, mental health. And then we also get into a lot of the Medicaid issues that you'll see, and that's what a lot of these different fact sheets deal with. I also mentioned earlier the disability etiquette fact sheet we have, which is fact sheet number 17 that we put out. So those are all fact sheets that we have put out so far. We also put out a series of fact sheets. After our first year, we recognized that some of the fact sheets that dealt with some more specific situations were the ones that were downloaded the most. So what we decided to do was create a new series of fact sheets that sort of helped you get to some of the information quicker. And these are population-specific fact sheets. So what to know when assisting a consumer with, and then whatever the specific condition is. All of these were written by organizations that have specific experience with these. And all of them except for the veterans one follow a very similar formula in terms of answering some basic questions about the disability. And so you'll see once you've read one of these, you'll get an idea of what's included in these, and then that gives you access and might point you to another fact sheet that'll give you more specific information about those issues. But it is a great place to start if you're assisting a consumer that is in one of these disability groups. The Veterans Fact Sheet is obviously more tailored towards the veterans healthcare system and was written by United Spinal, who does a lot of work with veterans health. One of the, when we were going through the NDNRC over the course of the first year, and then even after that, there were things that we sort of noticed were definite needs that affected people with disabilities, and sort of some of the common themes that we sort of saw, things that you need to be thinking about when you're really looking at this. So for instance, the deaf and hard of hearing, by far the most common inquiry I got early on from navigators was around the issue of sign language interpreters when they meet with consumers who are deaf and hard of hearing. This generally came down to an issue of funding, as the navigators generally did not have an issue with using a sign language interpreter. It became who pays for it. And this is a question that we did a lot of work on, and we really sort of tried to make people in the enrollment community aware of their requirements under this and making sure that you are providing this service to the consumer free of charge to them. One of the things I always mention when I talk about this area is, you know, when you're talking about sign language interpreters, if you're in a position where you're helping hire the people that do the direct work with the people who, to the consumers who come in to require assistance, the one thing I always get people to think about is when you are hiring individuals, if you're dealing with, say, for instance, an area of the country where you're dealing with a high Hispanic population, most people are going to actively look for and recruit people who speak Spanish so that they can communicate with that population group. When you're looking specifically at the issue of sign language interpreters, think about looking for people who know sign language and can communicate in sign language, so that you don't have to worry about providing that as a service that you'd have to pay for. It would just be one of the people on your staff knows that and then is able to communicate in that way. So if you're looking for a sign language interpreter and a cheap way to do it, that's the way to do it, is hiring people that know sign language, that can communicate with the deaf population, so that they are, so it doesn't even become an issue. You just have someone on staff that's able to do that and work with those individuals. Children with special health care needs. Families who have children with special health care needs face additional choices when they're considering health plans. So it really becomes an issue, and that's why we did the one fact sheet that we had on issues with specifically with dealing with children with special health care needs, because there is issues with, enrolling children in healthcare plans and making sure that they're going to be appropriate for them, and sometimes maybe getting them on Medicaid if Medicaid provides services that they would need. Behavioral health and substance use disorder. There's a lack of providers and network adequacy in marketplace plans. Additionally, these consumers generally usually fail to self-identify, which makes it more of a challenge to provide assistance. And this is in addition to ongoing issues around the operational implementation of mental health parity in insurance plans. Prescription drug formularies, getting access to the formularies and the limitations within the formularies are both issues which disproportionately affect individuals with disabilities. This is cross-disability, but obviously it affects people with mental health needs, multiple sclerosis, and other disabilities that obviously take great use of prescription drugs. For rehabilitation and habilitation therapies, there's concerns over limiting the number of visits as a way around the ACA's prohibition on dollar limitations. I talked about the monetary caps earlier, but there's not caps on services. Additionally, there are concerns about plans paying for maintenance rehab so that individuals don't lose abilities, and that can become a problem sometimes. Rehab also affects a larger number of consumers and is therefore cross-disability. And habilitation, I'll get into a little bit later, the difference between rehab and habilitation and why this is so important. Durable medical equipment and assistive technology. This category includes equipment and technology such as wheelchairs, breathing equipment, screen readers. It's been a challenge for consumers who use DME or assistive technology to learn what is and is not covered under a particular plan. Under the 10 essential health benefits, medical devices are required to be covered, but the law does not define what medical devices is, and HHS has not defined what medical devices are. So it's been left up to the states and the insurance plans to really determine that. So what is covered in those areas becomes, could be very different from state to state. Coverage for individuals newly receiving Social Security disability. There is a 24-month waiting period from the time that you are approved for SSDI up until when Medicare kicks in. So there's lots of times questions about those individuals and whether or not they can get on a plan in the interim or what other coverage is available to them, whether Medicaid would be an option. So those many times become issues. And then once the 24 months is up, making sure that they are not still receiving care, or insurance through the marketplace that would be being paid for premium tax credits, because they're no longer eligible once they receive Medicare, because that's considered minimal essential coverage. And then enrollment accessibility, making sure that physical navigators' offices are physically accessible, but also enrollment events, because many times offices are not the problem. It's when you do events out in the community that things aren't always set up in the best way and aren't always accessible, and making sure that that is taken care of, as well as making sure things are available in alternative formats. We realized it early on in the project that there was sort of a shift in ACA enrollment towards outreach and not just focusing on the technical enrollment piece. And we recognize that when people hear messaging around outreach and are you enrolled and what you need to do to get enrolled, and meeting with assisters, that many times people with disabilities have a distrust of experts that they don't perceive as having an expertise with their disability. So we funded community outreach collaboratives, or COCs, within our network to try and really make sure that we were able to sort of help build a bridge between the disability community and the navigators. So the COCs had the two primary tasks of building cross-disability collaborations with other disability organizations, and also trying to do outreach to the state navigators and assisters. to make sure that those two groups can come together, so that people with disabilities, when they reach out to the disability organizations that they work with, would be able to receive a referral to a navigator, and then the navigator then would have a place to turn to if they needed assistance understanding issues that come up. One of the things that we developed to sort of help people with disabilities, help navigators understand the needs of people with disabilities, is we developed a tool called Health Insurance Jeopardy. And with Health Insurance Jeopardy, if you're familiar with the game show Jeopardy, then you know that in the health insurance, that in Jeopardy, it's not about providing the answer, it's about asking the right question. And that's really important when you're talking about people with disabilities, when they're looking at their insurance, making sure they're asking the right question. Because if they're not asking the right question about what their plan may or may not cover, they very well could get enrolled in a plan that's not going to be appropriate for them. I'm not going to go through all these, but I do want to just highlight a couple just to give you an idea of what this is about. So for instance, prescription drugs. If the individual takes a prescription muscle relaxant, then you need to ask whether the qualified health plan has a tiered prescription medication benefit, where they may pay for different drugs in different ways, because they may have, most people are familiar with tiers in the sense of prescription drugs that are generic versus name brand. That's one tier, but usually lots of times there's specialty drugs that are even on a higher tier. And making sure that you understand where a person's drug falls and how that's going to affect the cost of the plan. Medical devices. If the individual is a wheelchair user, does the qualified health plan cover durable medical equipment, or DME? I said that before that medical devices is not defined, so making sure that you get the answer to that question and whether it's covered is going to be important for that individual. If the individual indicates that his condition requires to use a catheter, well, then the qualified health plan, you need to ask if it covers disposable medical supplies, because medical supplies are one thing, medical equipment is something else, and a plan may cover one and not the other, or cover them differently. Rehabilitation and habilitation benefits. Consumer uses rehabilitation therapy and says that she has to go repeatedly for it to have any lasting effect. We talked about maintenance rehabilitation earlier. This is what we're talking about. Does the qualified health plan put limitations on the number of rehab visits? Because that could then really become problematic for the individual if they really need it for maintenance, because the maintenance is important for that individual, because ultimately if they don't receive that, it could result in their disability becoming worse. For Medicaid eligibility, when you're completing the enrollment, on the exchange, you arrive at the question that asks about disability. When you get to this, you really need to ask yourself, does the individual want to apply for Medicaid? Because if you answer yes to this, if the person has a disability and you answer yes to this, it's going to put them in a Medicaid eligibility determination. And the individual, maybe because of their income or some other status, may know that they are not going to qualify for Medicaid, and you may not want to waste their time going through Medicaid eligibility determination. So even if they have a disability, you may want to answer no on this question if you know they're not going to qualify for Medicaid and don't want to waste their time going through a Medicaid eligibility determination. The summary of benefits and coverage document. If the individual is a wheelchair user, you want to know, does the summary of benefits and coverage say what the cost is going to be for such services as durable medical equipment? And this is important because lots of times a lot of this information is not included on this, and you've got to go to other documents to really get the answers to these questions. And that's one of the things we talk about in the fact sheets that I referenced earlier. Those first 3 fact sheets that we put out, the topical fact sheets, really deal with getting answers to these questions. For mental health, I always like to leave a blank for this one, because does the individual need coverage for mental health, as they may not self-report this to you? Self-reporting of mental health is generally not something that's always done, because people with mental health conditions many times don't like people to know that because of the stigma that's unfortunately attached to it, and therefore they may not tell you those things. So one of the things I always encourage navigators to do, if you're talking about hidden disabilities in general, it doesn't necessarily even just have to be mental health, it could be some other disability that's invisible. The simple way to do it is start to ask them about providers they see and prescription medications that they take, and that might lead to a discussion about their health and getting a better idea of what their situation is. You never want to come right out and ask someone if you've got a disability or a mental health condition, but you can ask about doctors and prescription drugs, as that might give you a better idea of what their situation is and what they're going to need access to. For our double Jeopardy round, we went ahead and did these based on the population-specific fact sheets that we did for intellectual disabilities. Question here: autism spectrum disorder, cerebral palsy, attention deficit hyperactivity disorder, seizures, and mental illness. What are common co-occurring conditions for people with intellectual disabilities? And this is a common thing among the disability community, is co-occurring conditions. Just because you understand one disability that the person has doesn't mean you understand all their needs, because they may have other co-occurring conditions. With mental health, lack of network adequacy, limited provider networks, lack of parity in coverage, high out-of-pocket costs, wait time to see providers. What are common issues with mental health treatment and qualified health plans? And this, unfortunately, is something you'll see over and over again within the exchange coverage, is some of these issues that come up time and time again. For multiple sclerosis, the 13 drugs approved by the U.S. Food and Drug Administration, which are available to reduce disease activity and disease progression for MS, this is the number which are considered specialty pharmaceuticals. I talked about tiered prescription medication benefits before. Well, all of them are considered specialty pharmaceuticals, so they're on that higher tier that goes beyond just prescription and name brand. It's another tier up, and many times the costs associated with these drugs are much higher. For paralysis, this is the difference in therapies between someone born with paralysis and someone who is paralyzed later in life. This is what is habilitation versus rehabilitation, and this is I explain this in a little bit more detail, and I'd like to really make sure that people understand the difference of these two things, because it could be the same exact service being provided to someone by the same provider, but because one is rehab and one is habilitation, the insurance company may treat them very differently. Generally, insurance companies do not mind paying for rehab, but for whatever reason, they do not like paying for habilitation. You also commonly see this with speech therapy. Many times children who had issues with development that are having trouble with speech will go to a speech pathologist and have the same sort of therapies that maybe someone who has a stroke and loses their ability to speak later in life, they'll go to the speech pathologist and receive some of the same treatments and same kind of services, but they're dealt with very differently because one is habilitation and one is rehabilitation. For the Veterans Administration, the number of priority groups used to determine who gets access to VA healthcare services, because they are put on a tier. There are 8 different priority groups. For example, veterans who the VA has rated at least 50% service-connected disability are placed in priority group 1. Veterans who receive VA pension benefits are enrolled in priority group number 5. So there are various groups, and they are all dealt with in a different way. You can read more about that in our veterans fact sheet. Accessibility questions, I want to go over all these individually, since we did go over the disability etiquette on accessibility questions later on. This will be a sort of a good review for you. See if you can get these as you're going through these questions. See if you can answer them before I provide the question. This is one thing you need to think about when assisting a consumer with paralysis. The answer is, what is building accessibility? Making sure that your building is fully accessible and can be accessed by individuals who will be using a wheelchair. In terms of accessibility, this is the one thing you need to think about when assisting a consumer with multiple sclerosis. We didn't necessarily talk about this one earlier, but what is having materials available in alternative formats, i.e. large print? Many times people with multiple sclerosis have problems with their vision and need things in large print to be able to help them read. For accessibility, the one thing you need to think about when assisting a consumer with intellectual disabilities: what is asking questions that verify the person understands the information? And don't just ask them if they understand, but make sure that they understand by getting them to verify that by repeating back the concepts to you. This is the one thing you need to think about when assisting a consumer with mental illness. And what is educating yourself about mental health conditions and trying to avoid the stigmas associated with that so the person feels comfortable talking to you and making sure that they are informing you about what their health needs are around the issue. And then the one thing you need to think about when assisting a consumer who is deaf or hard of hearing, what is the individual's preferred method of communication? Making sure that you are communicating in the way that is best for that individual and how they would prefer to communicate with you. And for Final Jeopardy, we have one more question on disability etiquette. This is the one word that sums up the best quality you can have when dealing with anyone with a disability. I mentioned this a few times already, so you should be able to hopefully get this. The answer is, what is respect? Just treating someone with respect and treating them as you would want to be treated is the best thing you can do. If you want to listen to all of these, they are all those categories we've done in individual YouTube videos, so they can be watched in quick 3 to 6 minute increments. If you want to watch all of them and learn more about that, you can access that on our YouTube channel, and that's the link for that. Ongoing challenges. As you're thinking of people with disabilities and what they encounter when looking at health insurance options on the marketplace, here's some ongoing challenges we've noticed. Limited provider networks, and that's obviously an issue with people with disabilities. Many of them have seen providers for a long time and want to keep those providers and those specialists. Making sure that they're on the provider networks when they're enrolling in a plan is critical. Limited formularies, making sure that the drugs that the individual takes are covered and are done so in a way that is not going to be cost prohibitive. Discriminatory pharmacy design sort of goes right along with that, and making sure that drugs are not, that the individual takes are not on the highest tier, or if they are on the highest tier, thinking about enrolling in a plan that may have more costs in the premiums, but is going to have less out-of-pocket costs, may actually save the person some money when you look at that. And really doing that cost-benefit analysis of judging the premiums versus the out-of-pocket costs. Plan transparency, just finding out what is covered on a plan and what's not. I always like to explain my own situation. The very first year the marketplace opened, I live in Maryland, so I went on the Maryland Exchange to see what was available, just to see if I was shopping for coverage, what would happen and what would be available to me. And I was looking for information to see, as I said earlier, I use a wheelchair to see if my wheelchair would be covered. I had a hard time finding information on that. And if I knew to ask that question and had a hard time getting that answer, imagine how much more difficult it is for someone who doesn't even know what questions they need to be asking. So make plans transparent has been an ongoing challenge that we've noticed. High out-of-pocket costs is another one. I mentioned this earlier a little bit with pharmacy design. The out-of-pocket costs, paying a little more in premiums sometimes ends up saving the person quite a bit of money in the long term. And try and really encourage people to look at what their total healthcare costs are going to be under a plan. Confusion on the definition of rehabilitation and habilitation services and supports. I talked about this a little bit already, and what is covered and what's not. And lots of times that can become problematic for insurance companies and people who are trying to receive services for those areas. Confusion on the coverage of prosthetic devices and durable medical equipment. As I said, medical devices are covered, but it doesn't necessarily say what that is under the Affordable Care Act. So really understanding what is covered, what limitations there are, can become problematic, and it's something that we have followed over the years. And making sure you understand what is offered to a person in a plan is going to be important if they're going to need those. Confusion about coordinating exchange coverage with Medicare and Medicaid. As I said earlier, someone might need to use exchange coverage as a bridge to get them to Medicare or Medicaid, and understanding what needs to happen when the person goes on one of those benefit programs, and making sure they come off the exchange if they're receiving premium tax credits, because they're no longer eligible for those once they get onto one of them. Delays in getting plan information once people are enrolled. You enroll, in the beginning of December, but you don't get your enrollment information or your medical card until, it's already January or something like that. That can cause problems for individuals if they need to get a prescription filled or need to make a doctor's appointment early in the year, and making sure that that's taken care of. And encouraging individuals, if they are on a current plan, if they are going to need, prescriptions refilled, thinking about doing it in this year before the following year in case there are delays. And communication issues for deaf of hard of hearing. We've dealt with this before, making sure also that there are issues many times when people call into the hotline and trying to communicate. Sometimes that can become problematic for those individuals as well. If you want to stay involved with our project, this is how you can do it. You can receive updates. You can sign up at the website, which you see the address for there. We also have our newsletters that we put out every Friday, and you can get those. The archived ones are available on our website as well. Our organization also puts out a general newsletter, and you can sign up to receive that at that third list. And we also have a resource center that generally talks about disability resources and disability and health. You can check out our resource center. And that's what I have to talk about today. At this time, I'm happy to take questions from individuals who may have them. So I'll open it back up and see if there's any questions.
Thank you so much. And again, if anyone has any questions, we're not doing verbal questions, but if you can type them into the question box, which again, you can access it. There's a little Q&A icon on the bottom of your webinar toolbar screen. You just click on that. It pops up a little question box and you can type your questions in there. I'll give you guys a few minutes to sort of type in any questions that you have. Just as a reminder, we're gonna distribute the slides and a video recording of the presentation today. So you guys will have access to all of these links. I put a bunch of the links in the webinar chat, excuse me, the little chat box, but you'll also have them when I send around the slides, and then we'll post the slides later today, and we'll have the video recording up tomorrow. And we'll also include the resources that Carl talked about throughout the presentation. If you guys come up with any questions, if you have questions that you think of later, if you would like more sort of personal questions about kind of getting on the newsletter, or if you have questions for Carl, please email us. You can email myself, Hallie Cloud. You can email Carl. You can see his email on the screen as well. Please email us, and we can get answers to you as soon as we can. If no one has any questions, I know we're a little past time, so we'll close up the webinar. Again, we're going to be distributing all of the materials. I'll send around an email, and we'll also post them to healthreformbeyondthebasics.org. Our next upcoming webinar is on Tuesday, October 23rd. So next Tuesday, it's from 3 to 4 p.m. Eastern Time, noon to 1 p.m. Pacific Time. So it's a little bit later than our normal webinars. And we're going to be presenting that webinar in partnership with the National Immigration Law Center. And it will cover immigrant eligibility and the enrollment process for families that include immigrants. You can register for that webinar on our Beyond the Basics website under upcoming webinars. Again, we have lots and lots and lots of webinars and resources posted to that Beyond the Basics website. We just recently, I believe on Monday, posted a webinar on plan selection strategies. And Carl talked a lot about when you are helping someone enroll in a plan, making sure that certain doctors are in network, if you're looking at formularies, and we go into some strategies and sort of ways to look into the summary of benefits and coverage, and actually going on to some of the provider or insurance company sites to sort of wade through where all of these things are kept and how to find this information, what questions to ask when you call an insurer, if you call the marketplace. So that will be a good webinar as well if you have more specific questions on strategies for how to really delve into plan choices. And also about comparing costs and comparing premiums versus your actual out-of-pocket costs for the year. So again, that webinar is on our website at Beyond the Basics. Again, if you have questions or need assistance going forward, please email myself for that Beyond the Basics contact. You can also email Carl about questions specific to this presentation. So again, that webinar is on our website at Beyond the Basics. Again, if you have questions or need assistance going forward, please email myself for that Beyond the Basics contact. You can also email Carl about questions specific to this presentation. Please email Carl about questions specific to this presentation. With that, I think I will bring this to a close. So thank you again so much for joining us today. And a huge thank you to Carl and the American Association on Health and Disability for doing this webinar for us. We really, really appreciate it. So thank you so much. And we will talk to you all hopefully on Tuesday. So thank you again.